Thank you very much, Sandy. We will continue our last session of the day and the most important session, the quality in neonatology. And it's my pleasure to introduce Dr. Barbara Schmidt, who is a professor at University of Pennsylvania and professor part-time at McMaster University in Ontario. Everybody actually knows Dr. Barbara Schmidt. She's and Dr. Harish Kripalani. She is the author of 3 major trials, which we all learned a lot from. That is the TIP trial, which is the trial of intravenous prophylaxis in preterm, and most famous one, the CAP trial, the caffeine for the apnea of prematurity, and Canadian oxygen trial, the COT trial. She was worked with the University of Pennsylvania and the Children's Hospital Jobs, NICID, Neonatal Research Network. So with Dr. Harish Kripalani, she built a sizable team for young and junior investigators who are enthusiastic about the contribution to the clinical research. So she did a lot in clinical research for neonatology. And today also she's going to talk about collaborative controlled clinical trials, what makes the difference between success and failure. Over to you, Dr. Barbara Schmidt, and sorry for a little delay, but sometimes it happens. So over to you, Dr. Barbara Schmidt.
Thank you very much for this. Good evening in Abu Dhabi. And thank you, Dr. Khan and the organizing committee for inviting me to participate in this 11th International Neonatology Conference. I will discuss collaborative controlled clinical trials and address the following question. What makes the difference between success and failure? I have no financial relationships to disclose. However, I will use the caffeine for apnea of prematurity, or CAP trial, as a case study in this talk. Therefore, I should mention, although Dr. Khan has already kindly done so, that I was the lead investigator of the CAP trial. Controlled clinical trials were introduced into medical science less than 100 years ago. Until then, physicians relied on experience, intuition, and uncontrolled experiments. The detrimental consequences of their actions remained mostly hidden, but we get a glimpse of poor practices by studying prominent victims of anecdotal medicine. For example, George Washington died in December 1799 at his estate in Mount Vernon soon after developing a throat infection. During his final hours, his treatments by several different doctors included bloodletting. 80 ounces of blood, or about 40% of his total blood volume, were removed within 8 hours. It has been disputed if this extraordinary and fairly acute blood loss was the actual cause of his death, but it could not have helped. The late David Sackett is widely known as the father of the evidence-based medicine movement. Here's what he had to say about bloodletting. 100 years after Washington's death, orthodox medical practitioners were still using bloodletting routinely. The reason why smart doctors continued to use dumb treatments was because they were prisoners of inductive reasoning as the proper route to truth. They were brilliant observers, but they were not experimenters, and observation cannot prove efficacy. The benefits of large randomized controlled trials are obvious. Without them, in perinatal neonatal medicine, we would be unable to confidently prescribe effective therapies such as antenatal steroids for threatened preterm birth, surfactant for preterm RDS, or therapeutic hypothermia for term infants with moderate or severe hypoxic ischemic encephalopathy. And equally, without those large collaborative trials, we would not be able to get rid of useless or unsafe therapies, such as routine resuscitation with 100% oxygen at birth, or routine endotracheal suctioning for meconium-stained amniotic fluid. Caffeine for apnea of prematurity has been called a neonatal success story. The authors who wrote this article credit the CAP trial for much of this success. So what made the CAP trial a success? On this slide, I have listed what I consider to be the most important ingredients for a successful collaborative trial. Firstly, we must ask a sound study question. Secondly, we need a strong network of collaborators. Thirdly, we need a supportive funding agency. Fourthly, we absolutely must work with an experienced and with a proactive DCC, which stands for Data Coordinating Center. And lastly, we also need a reasonable amount of luck. And this is because the best planned trial may encounter threats to its successful completion that turn out in some cases to be beyond the investigator's control. In the CAP trial, we managed to tick off each item on this wish list. So let's begin our case study with a closer look at the study question. And here it is in the PICOT format. Among infants with birth weights 500 to 1250 grams at risk of apnea of prematurity, does neonatal caffeine, when compared with placebo, increase the risk of death or disability at a corrected age of 18 months? Note that we set out to examine the safety of routine use of caffeine, and we therefore hypothesized that caffeine may actually increase or worsen developmental outcomes later in childhood. Thankfully, we were proven wrong. Here are 4 criteria by which we should judge the quality of the study question, and this applies to all research questions, not just the CAP trial study question. These criteria are uncertainty, clinical importance, scientific plausibility, and feasibility. Uncertainty means simply that the study question has not previously been answered. In the case of a treatment trial, there should be sufficient doubt about the risks and benefits of the test intervention. But I should stress that uncertainty is not another term for ignorance. We can reach a conclusion of uncertainty only after careful review of all the available evidence. In 1998, I was on a short sabbatical and in a relaxed mood. And one day I was browsing the website that in those days contained the neonatal Cochrane reviews. Of course, there were far fewer back then than are available to us today. Later that same day, I wrote to a good friend, Peter Davis, in Melbourne. I was absolutely horrified to see how few infants have ever been randomized to theophylline or caffeine, and that all we know is that these drugs reduce short-term apnea. I did not honestly know that the evidence was quite this flimsy. In the following year, I published this invited commentary in the Journal of Pediatrics, and the goal really of this article was to raise awareness of the limitations of the clinical evaluation and the available evidence on this class of drugs, the methylxanthines, which include, amongst caffeine, also aminophylline and theophylline. And the whole class really has the same types of actions. For the title, I borrowed the classification of sound practice, disaster, or fruitless byway from the late Bill Silverman. And those of you who have read his work, Dr. Silverman was a pioneer of evidence-based neonatology before that term had been invented. The next criterion by which to judge the quality of the study question is its clinical importance. And in the case of a randomized treatment trial, it is really not important only what we ourselves think about the importance. We tend to think it's important if we want to study it. No, we really need other people to believe that it's important, because in a trial like this, we need buy-in from our colleagues and the families of our patients in the case of our neonatal specialty. These people must want to find an answer to our study question because it makes a difference in their medical practice and in their lives. And it is a fact that commonly used practices will attract more interest than therapies that are rarely prescribed. So in 1998, which was the year in which we prepared the grant application for the CAP trial, I contacted Shu Li, who was then the director of the Canadian Neonatal Network, to find out how commonly mesoxanthines were actually used across Canada in the 2 preceding years in our target population. And here is his answer, and you can see that close to half of the infants received methoxanthine on day 3 of life. So this confirmed fairly frequent use despite the flimsy record of clinical evaluation at the time. Of course, today those numbers would be closer to 100%. Scientific plausibility is the next criterion by which to judge the study question. If we test in a treatment trial a novel therapy, of course we should have a biologic rationale for its hypothesized benefits, and I should add at least some preclinical evidence to its efficacy. If, however, we question the safety of an existing therapy, as we did in the CAP trial, we must be able to provide experimental evidence that suggests potential harm. So why were we concerned about the safety of routine use of caffeine and the other methoxanthines? Caffeine and aminophylline and theophylline are all non-specific inhibitors of adenosine receptors, at least at the standard drug doses that we tested in the CAP trial. Adenosine is produced in all our tissues, including the brain. And the adenosine levels rise in the brain when energy demand outstrips supply and brain cells are at risk of dying. Such situations of an imbalance between ATP synthesis and ATP breakdown include hypoxia, ischemia, hypoglycemia, seizures. You recognize the conditions that, unfortunately, we encounter quite regularly in our very preterm patients. So adenosine protects the brain from permanent injury due to energy failure. And when we block these receptors with caffeine or other methoxanthines, we basically inhibit a natural protective mechanism. And certainly in multiple animal models, this has very unpleasant consequences. Feasibility is the final criterion by which to judge the study question. Many investigators underestimate the difficulties they will face in recruiting the patient sample, administering the study intervention, and following all study participants for the most important outcomes. It is, of course, easy to judge feasibility in hindsight. History has shown that the CAP trial was feasible. We enrolled the target sample size of 2,000 infants, and we assessed outcomes in 3 follow-up phases at 18 months, 5 years, and 11 years. Attrition was very low at 18 months and still acceptable at 11 years. Having discussed in some detail the aspects to consider when formulating and evaluating a question, in this case for a treatment trial, we move on to the network of collaborators. Our network was not a formal network, such as, for example, the Neonatal Research Network in the US. It was more of an ad hoc network of friends and friends of friends. In some ways, this actually had some advantages. because each participating NICU made an individual and local choice to join this particular trial. This slide shows some, but not all of the CAP investigators because they would not all fit onto one trial. But the point here is that generating enthusiasm in many people and then keeping the momentum going for a good number of years is one of the biggest challenges once a trial is underway. It takes a fair amount of ingenuity and effort. But ultimately, it's about building and then maintaining relationships. This painting by Edward Hicks is called Peaceful Kingdom, and it hangs in the National Gallery in Washington, D.C. Many years ago, my husband sent me a postcard reproduction of this painting with the following words scribbled on the back. This is your version of the truth. The lamb and the lion and the baby all lie down in peace and harmony together. And here's quite a different version of the truth, vividly expressed in this painting by Charles Rowley in the same gallery and entitled Law of the Wild. Relationships among collaborators may not be always entirely harmonious, but they certainly should never be savage. A few words about funding. In the Canadian Institutes of Health Research, short CIHR, we certainly had a supportive funding agency, and I will explain in the next 2 slides why I'm concluding this. Problems with patient recruitment or patient accrual are the single most common terminated early, both in adults and children. This particular study was published 5 years ago in Pediatrics, and the investigators here just examined pediatric randomized trials, 104 of them that had been discontinued before the planned sample size had been enrolled. And you can see that of the reasons given as to why these trials basically failed, problems with patient accrual topped the list once again. So there are no surprises. In this collection of abandoned trials, patient accrual problems were amounted to more than 1/3. In this situation that I just showed you, funding agencies respond differently, and some are discontinuing or cutting off funding more readily than others. As I had indicated, CIHR was very supportive and patient, and I'll show you why. This is an early recruitment graph for the CAP trial. So this is from one of our many internal documents of those recruitment graphs, and it shows the dotted line across is the anticipated or expected recruitment, and the solid line, the actual recruitment. And this is about the first 15 months into the trial. And you can immediately see that our early enrollment was slow and woefully behind expectations and predictions. We responded to these depressing statistics by adding new study sites and by actually extending the enrollment period from 2 years, which we had optimistically projected, to 5 years. I must add, however, that we did not ask the funding agency for extra money, just extra time. And this, of course, is only possible if your budget is a budget per patient enrolled and followed, not a budget per study site, where the site receives a payment, a fixed payment, irrespective of performance. And I'm sure you can guess that I am a great fan of the per patient budget because it gives you a lot more flexibility to cope with problems such as recruitment problems and also to reward good performance. I cannot stress enough the importance of working with an experienced and proactive data coordinating center. A successful collaborative trial needs a lot more than a central database. Our study coordinators at McMaster University were in touch with the staff and investigators at the local sites frequently and sometimes daily if necessary. They perused and reviewed incoming data, issued data clarification requests where necessary. Every month, study reports were prepared for recruitment, record completion, follow-up completion, sent out every month for many years with a monthly newsletter. The coordinators worked particularly hard with the local sites when it was becoming apparent that babies and children might slip out of follow-up windows to try and see how one could go jointly the extra mile to salvage this particular assessment. Basically, we wanted to know at any one time what exactly was going on in the center with respect to our trials. And we actually had a motto at the Neonatal Trials Group, and that was no news are bad news. Professor Robin Roberts, our senior statistician shown here on the right-hand side, was involved in our projects from the very first beginning, from the initial formulation and fine-tuning of the study question. We took the warning of the great Sir Fisher, he of the Fisher's exact test, very seriously. Sir Fisher is quoted as having said, "To call in the statistician after the experiment is done may be no more than asking him to perform a post-mortem examination. He may be able to say what the experiment died of." And then there is luck, because as I said, things can happen outside of your control that may actually completely derail the trial. And I think in neonatology, for me anyway, the most memorable and sad example is DART, dexamethasone in tiny babies, a randomized trial. Lex Doyle and his colleagues in Australia designed and launched this trial at the turn of the century, so about 20 years ago. And the next slide shows you the DART study question. Basically, they wanted to resolve the uncertainty that we collectively have about the risks and benefits of moderate doses of dexamethasone given to extremely preterm or extremely low birth weight infants who are stuck on the ventilator after the first week of life and therefore have evolving BPD. And the main outcome was death or disability at 2 years. But just as this trial was beginning to be underway, within a few months, a tidal wave of expert opinion swept through the neonatal community, condemning basically all use of postnatal steroids. I call it hysteria, what happened back then, but the consequences were devastating because within a very few short months, enthusiasm for this trial was so severely dampened around the world, it was an international trial, that enrollment had to be abandoned after just 70 infants had been enrolled when the target sample size was well over 800. And wouldn't it be nice in 2021 if we had the answer to this question? In my view, looking at the neonatal trials out there and those that have been unsuccessful, I think that we allowed this to happen is one of the greatest tragedies of neonatal research. A final few words about the principles of research ethics. Basically, the principles of research ethics are no different than the principles that should guide all of our interactions with our fellow human beings. They are respect for persons and their dignity, beneficence, and justice. In our trials that we conducted through the Neonatal Trials Group, and later in the Neonatal Research Network, we have seen that if research is introduced to families with honesty, trust, and respect, and also conducted in this spirit, then most parents actually respond very positively to this type of research. And they may see their research participation more as an opportunity than a burden. But having said this, there is no question that some unethical investigators exist, including today. The French artist Honoré Daumier, quite some time ago, already knew that every profession has a few black sheep, and physicians are no exception. In this drawing by Honoré Daumier, you see this feeble elderly lady in the armchair in the background, and in front, those are two physicians who are having the following conversation. "Oh no," one of the physicians says, "the patient is weak. She wouldn't survive. The operation is impracticable." The other answers, "Impracticable? Nothing is impracticable for a beginner. Listen, we have no name yet among the profession. If we fail, we don't lose anything. If by chance we succeed, we'll be launched. Our reputation will be made. And both, let's go ahead then." I thank you for listening, and I look forward to our discussion later on.
Much, Dr. Barbara Schmidt. We have to have you in our panel discussion, which is in the end of these next talks, 3 talks, and then we have already received some questions. By the way, Dr. Ola Sagaspat saying hi to you in the chat box. So, so he's just there. It's my pleasure to introduce our next speaker, my colleague, and I must say my elder brother. I'm just kidding. Is Dr. Mohammad Kasabne. Dr. Mohammad Kasabne is working in Dawam Hospital with Dr. Ayman Rahmani. We are very good collegialship. He graduated with residency in Iowa City, University of Iowa. Then he did 3-year neonatal fellowship at Case Western Reserve University in Cleveland, Ohio. Dr. Kasabne joined the Jordan University of Science and Technology and became the full professor. Then he moved to UAE and worked in the Dawam Hospital for a little period. He went back to Jordan and then come back now. Again, he's board certified in general pediatrics and neonatal and perimental medicine. He also has a 30 published research paper in areas of breastfeeding, neonatal sepsis, and neonatal jaundice. And today, Dr. Kasabne is talking about the management of neonates at the edge of the viability, ethical, and clinical challenges. So, Dr. Kasabne, it's over to you.
Introduction. Thanks also to Dr. Ayman Rahmani for both of you for organizing and inviting us to this nice conference. Also, I'm pleasure to be following Dr. Barbara Schmidt, who finished her talk talking about ethics of research. And I will continue talking about ethics at the age of viability in our neonatal population. I have nothing to disclose financially. My objectives of the talk today is to talk about ethical principles and how they apply in neonates. I will discuss question at the age of viability, explain best interest of the patient as a concept, and then discuss factors affecting decision-making at the age of viability, and then discuss some approach for the age of viability. I will start with this research done by Jonathan Tanaroff, who this is published in 2014 under the title The Ethics and Practice of Neonatal Resuscitation at the Limit of Viability and International Perspective. Neonatologists attending an international meeting were surveyed about the delivery room behavior. And let me explain this slide because that is the main result of the study. So what they ask people is, what do you do? Do you start full resuscitation, everything? A. B, you start with pulmonary resuscitation, but you don't go to cardiac intervention. That is B. C, you withhold the resuscitation. You will not provide resuscitation. So A, full resuscitation, B, partial, C, withhold resuscitation. And then they give different scenarios. And in each scenarios, the baby could be 22 weeks or 23 weeks or 24 weeks. So the scenarios are divided into a high-risk scenario like a male with no steroid, or a good scenario that the baby is active, or a female who received the steroid. So, and they looked at the response of people, what they do. So if you look at one bad scenario or a high-risk scenario where a male without a steroid, and we take 22 weeks, then we see that most people choose C, which is not to allow resuscitation. While if the baby is active and crying, and yet at 22 weeks, the same people would be divided between giving full resuscitation, partial, or no resuscitation. While if it's a female who have steroids, some of them will give resuscitation at 22 weeks, and most people still not giving resuscitation. If the patient is very hypoactive, bradycardic, not responding from the beginning, then most people at 22 weeks offer no resuscitation. If you look at the 24-week in green, everybody want to give resuscitation except in scenario number 4, there is some distribution. Where for 23-weeker, there was always some distribution between giving or not giving for resuscitation. So the conclusion of the study, there were strong preference for comfort care at 22 weeks and full resuscitation at 24 weeks. And resuscitation was in a gray area at 23 weeks. And also they asked them some questions and conclude that there is many cultural, social, legal factors that determine the behavior of the neonatologist and their decision regarding the age of viability. So what are the management options do we have? We now understand we have either to go for full support or go to withholding of support, not initiating therapy, or start a therapy, then evaluate, and then decide if we want to continue or withdraw. And in some ethical dealing with end of life, some people do active termination of life, which is not very popular among the neonatal population, and we don't want to discuss. Now, with this type of decision, that takes us to the ethics of regarding our decision. And now I will start to, what is the definition of ethics? So there is no clear definition of ethics, but ethics is maybe the tool that we know the right from wrong, that we kind of compare the right thing from the wrong thing. Or maybe ethic is things are ethical when they are good for us, when they add good thing to our life, and unethical when they add bad thing or make our life worse. Now we wish always to look at things from black and white, very clear demarcation, that this is ethical, this is non-ethical. But when it comes to our question about neonatal care and ethics related to it, unfortunately we go into the gray color. And things are not very clear, and we should work together to reach to the best decision to be offered for the patient and the family. So what are the principles of ethics that we need to apply or think of when we are talking about medical decision? There are 4 principles to remind everybody in the audience to know regarding ethical principle: autonomy, beneficence, non-maleficence, and justice. And let's see how these would apply into the neonatal population. If you look at the autonomy, for example, related to neonatal care, then the autonomy by definition is the right to accept or refuse the treatment, but a neonate cannot do this. So should we treat all newborn give them full treatment because their will is unknown? Or do we always have to respect the parent autonomy as they are the surrogate for their children? What about the best interest of the baby? Can this be contradicting with the parent wish? Also, should we consider best interest of family? Because the child is part of their family, and we should consider them one unit and look at them as a holistic approach. And when and how can we contradict parent decision, especially more challenging in certain culture in certain countries? Now, we're talking about parental autonomy. Let's just discuss it a little bit more. Parents have the right to get the information. They need to make an informed decision on their child's behalf. They have the right to decide what is the best done to their child. Their decision may be overridden by the child rights. We have to be advocate for children. And that happens when the parent refuse a treatment that we think is clearly of benefit to their children, or sometimes they demand a treatment that is clearly harmful. And that is more common scenario because parents are not trained or educated to be a physician or medical professional. The second principle and its application to the neonatal population are two principles, beneficence and non-maleficence. And that's basically what we say, the best interest of the child, not to give them benefit and not to harm them. So when the prognosis is so poor, resuscitation or any intervention is useless, then it is not allowed. So the prognosis decide what is of benefit for the child. When the prognosis is good, in that scenario, resuscitation should be provided and should be obligatory. But the problem, the prognosis sometimes is unclear, and it's difficult to determine the relative benefit and burden of the resuscitation. And that is where the gray zone happens. And we need to do a shared decision and different approach. Let's talk about best interest in neonate. Do you think that keeping life with potential morbidity and its burden a good thing for the baby? You should resuscitate regardless of the outcome, regardless of the future of these children. Also, we should distinguish between parent and baby suffering. Both of them should be considered, but the baby suffering also should be thought of because they're lacking autonomy. The second thing we have to think about is the developmental outcome score that we measure and decide on are dependent on when do we take them. If you take it at 2 years, might change at 4 years, might change at 10 years. If you get a developmental outcome at 10 years, it's reflecting a neonatal care 10 years ago. If you take a developmental and outcome at 20 years, it reflects the care in the late 90s and early 2000. So it's very tricky when we are talking about prognosis and outcome in the neonatal period. The other thing about best interest is very subjective. And one important point is physicians are very highly achieving human, and we are the one who do the counseling. And we think the standard is to have a child that will have high IQ and high achievement. So we may be subjectively biased when we are counseling and judging quality of life. Some studies show that extreme low birth weight infants are rating their health-related quality of life comparable to the normal birth control. So they are happy with what they get. So something needs to be discussed further before we decide about offering treatment or not. Justice is to treat people equally unless there is a relevant difference between them. And many people feel that the neonatal population are treated differently than adult and even children. Because some disease like car accident with children or some encephalopathic related to infectious disease might do a very much worse outcome than extreme prematurity, and yet nobody discuss withdrawal or withhold of treatment in this population. When it comes to neonatal population, we are trying to treat them different because we think they are just a little human being maybe. So justice has to be thought of deeply when we're dealing with the neonatal decision making. There's another concept called distributed justice. People thinking that the money should not go to, to be spent on certain extreme babies, and that will consume resources. But many people argue that NICU care is relatively less costly than adult. For example, very preterm babies die quickly. 70% of them, they die in the first 5 days of life. So the cost is only for a short period of time. And if you look at the NICU as intensive care bed, 9 out of 10 NICU beds are devoted to babies who survive, while 4 out of 10 in adults, they survive. And most survivors are productive citizens, with some caution about this data, because in extreme premature baby, they can have a lot of challenge in the future. So let's also see how the law people, this is a professor in law from McMaster University, and she says that natural intrinsic are to try to save all babies. So we have to try with everybody, even if the chance of survival are low. However, we do not think it is always right to put baby through the stress and pain of intensive treatment if the baby is unlikely to get better and death is inevitable. So I put the unlikely to get better is a probability, not a definite thing. And medicine is not a disease, a science of definite answer. It's a disease of it's a science of probability. So we have to balance and think on every case by case and see what is the probability of survival and what is the probability of getting better before we decide about life and death. And that takes us to another concept that us as a neonatologists are not well trained about, and that's medical futility. In Oxford Dictionary, futility means incapable of producing any useful result or pointless. And futility means pointless or uselessness. While medical futility is defined or described as a judgment that a further medical treatment of a patient would have no useful result. So when we decide a treatment is futile and it's pointless and it's useless, that is when we don't offer it. And that takes us to another concept that we use and we interchange, and that's viability. And viability, by simple term, is the ability to live outside the womb. Some people define it as gestational age at which survival is 50%. And currently it's around 24 weeks. So viability is 24, but we are also thinking of offering treatment at the peri-viability because it's not zero in the lower side of the 24 weeks. But we know that gestational age is frequently used in determining the age of viability. But we have also to understand, and I'm sure most of the neonatologist audience know this, but it's just just opening some thoughts for discussion, that birth weight, gender, plurality, and use antenatal steroid change the outcome. Of course, where you practice and your resources and what's your philosophy about active treatment regarding certain gestational age will determine the outcome. But when we are using gestational age as the tool for age of viability, we are hugely challenged by many things. And the main thing is the accuracy in gestational age, because gestational age, depending on last menstrual period, is not accurate. If we are using early ultrasound, it might be a few days to 1 week. But if a late ultrasound is used to determine the gestational age, the accuracy can be in the range of plus minus 2 weeks, which is a huge variation that affect our decision. And if we wait for the baby to come out and have a senior doctor attending the delivery at 23 weeks, I don't think it's very easy for any of us to look at a 23-weeker and know if they are less and they are more toward the 22 weeks or they are more toward a 24 weeks. So physical examination at the time of birth is not an easy tool to assess gestational age. But yet, still gestational age is used as a tool to estimate survival for extreme premature baby. And this is the NICH network calculator that gives you the outcome according to the data collected in 2000 in the year 1998 and 2003 from 19 centers in the US. It's still reflecting a US data, maybe also an elite centers in the US. And the number also, it is reflecting a different time period than what we are practicing today. Now, if we look even at this calculator and put some arbitrary, I would say, numbers, like put a 24-weeker 500 gram and then change risk factor, and then put a 24-weeker with 1,000 gram and put them a favorable risk factor, we find the survival in the first one at 17%, while in the second one is 93%. So there is a huge variation in the outcome in the same gestational age, depending on what risk factor is present at the time of birth. And this has to be in a complex way assessed and incorporated with the discussion with family and in the decision making, which should sometimes happen within half an hour or 2 hours when the mom rushes into the ER with a fully dilated cervix and is contracting and is ready to expel a premature baby. Again, another challenge in gestational age and cutoff point of viability is outcomes changing with time. This is the Sweden data for survival. If you look at the time period from the 1985 till 2015, you can see, for example, this color represents a 23-weeker. That 23-weeker outcome is improving with time. So you cannot use the outcome in the mid-90s to counsel a resuscitation in the 2010. You will be giving the parents a false information about the outcome. The same thing for 22 weeks and even for 24 and 25 weeks. So this data is evolving, and the cutoff for what is considered an age of viability is changing with time. I cannot move on without sharing with you this New England Journal of Medicine publication that was done by one pediatric resident who took the NICH data and analyzed it in further way. So they looked at between hospital variation in treatment and outcome in extreme preterm infant. And I just need 1 minute to explain this slide. So this is 22 weeks, this is 23 weeks, this is 4 weeks, 25 and 26 weeks. And the y-axis is looking at the active resuscitation. If you look at the 24, 25, and 26, most people do full resuscitation, almost 100% resuscitation is offered. And the line here, the width of the line reflects variation between one center and another. So there is not much of variation at the 25, 26 week, and to some extent to 24 weeks. But once we reach 23 and 22 weeks, we'll see the lines of variation is wide. Here is very wide. So some centers are giving this much rate of active resuscitation versus this much rate of resuscitation. And this even changed from 22 weeks with 5 days and 22 weeks and 6 days. Even 1 day make a difference in the approach people do. Now, how this would reflect into outcome? When they looked at the survival at 22 weeks, survival at 22 weeks, the centers that do full resuscitation, these dots, have a better survival, much better survival than the one that do not do active resuscitation. Of course, this is, it makes sense and logic, but at that, people sitting in this area think it's worthless, it's futile, and it shouldn't be tried to give resuscitation because nobody would survive. But people who tried achieved this survival. The same thing applies for 23 weeks. Centers that do less resuscitation have much less survival than the one that approach all babies at 23 weeks and give them resuscitation. So of course, this is neurodevelopmental survival without severe impairment. So of course, these babies will have impairment, and that is probably the other, pulling fact that makes us a little bit cautious about offering full resuscitation. I put this slide because when we counsel parents, we need a slide like this, a data like this. You take this is a data from Vermont Oxford Network 2014. You take 100 baby and say how many of them get resuscitated, for example, in that network. 88. 47 survive. So out of the 47, 20 have neurodevelopmental impairment that is significant. So we are left with from 47, 20 have the neurodevelopmental impairment. We are left with 27 who are not having neurodevelopment, but 14 of them will have neurobehavioral, educational, and social impairment. So when we counsel the parents, we should be honest with them that only 13 will have normal life if you are looking at normal life. Absolutely no impairment. So the number is different than saying 50% survival or 60% survival. So it has to be in a simple approach and very clear way, and an updated outcome data that reflect also the local outcome in that particular hospital. So what are the approaches to the age of viability? Either to follow like legislation or a guideline or a policy in the hospital and say everybody above this gestation age we should resuscitate and there is no DNR. But this ethically in some way violating some of the principle of the ethics, maybe all of them, because you might harm some babies and you don't respect autonomy, and we may treat these people in an unfair way. Or apply ethical principle of autonomy, beneficence, and non-maleficence and justice in your way, so you have some flexibility of offering treatment when it is beneficial and withhold it when it is causing harm with some respect to the autonomy. Now, other approach which use the same thing that is in the first two approach, but they have different name called ordinary, extraordinary approach, means that, ordinary is the treatment that when you offer it, you make a difference. The extraordinary are a treatment, it just increase the burden and the suffering and has no benefit. Shared decision approach is another approach. It's called shared decision. We share the parent with the information they need, but we support them with their decision. So that is the ordinary, extraordinary. I already explained it to you. The shared decision approach, as I said, we have to just put the parent in the context of what they are expecting and then support them. We don't negotiate with them the best interest model. We don't establish moral truth or ethics. We just go with what they feel the best for them. And in this approach, we have to be aware that there is a huge stress that will be on the parent in taking decision of life and death in their own children. And this might stay with them for the rest of their life. So we have to be very supportive and give them the best information available. In this shared decision, an initial decision to resuscitate and initiate intensive care measure is reversible. So the parent should be made aware of this, that if they go for a treatment, of course reversible if you go for the treatment and then more complication appear, then you can withdraw support. In UAE, we cannot do that because the law of the UAE doesn't allow withdrawal of care. Now, for medical ethicists, they clearly believe if it would be permissible not to offer resuscitation, it would also be permissible to withdraw support. So they don't see a difference between withhold of support and withdraw of support. I will finish my talk with a few slides, just sharing how the American Academy of Pediatrics tackled the problem in the beginning of the century with certain statements. So the first one is the AAP non-initiation or withdrawal of intensive care statement in 2007. And they say treatment that is harmful and of no benefit or futile and merely prolonging dying is inappropriate. So that is the frame that we should work with in making decision. We shouldn't commit to a certain numbers or absolute, very rigid rules. We should just put in our mind that anything that is harmful without a benefit, it should be inappropriate. And the large organization supported. Also in 2009, the AAP Committee on Fetus and Newborn say the following: if physicians involved believe there is no chance of survival, resuscitation is not indicated and should not be initiated. So we're talking about close to zero, our belief of a zero survival. If the physician consider a good outcome to be very unlikely, the parental choice regarding resuscitation should be respected. Like if the risk of disability is very high, this where the parent have the choice to be involved in the decision. When the physician judgment is that the good outcome is reasonably likely, resuscitation should be initiated. If we look at the NRP and what they say about the age of viability, for example, in 2010, when gestational age or birth weight are associated with almost certain early death, and when unacceptable high morbidity is likely, among the rare survivors, resuscitation is not indicated. Example, that is in 2010. Example include gestational age less than 23 weeks, like the 22 weeks were included, or birth weight less than 400 grams. But in 2006, NRP changed, and they said we should only withhold the treatment for a confirmed gestational age less than 22 weeks. And we have discussed that the outcome is evolving. There is more survivor among actively resuscitated 22 weeks. So in conclusion, human has the right to live and get optimal treatment. Ethical principles are challenged in the neonatal care at the age of viability. Treatment measures should focus on the best interest of the patient, but that's very tricky in this population. Viability at a specific gestational age is continuously changing with improving neonatal care, but also should be considered according to your local data and local ability in that particular country. In gray zone, the parental informed decision is very important and should be respected. I will finish with this statement from Dr. Eric Kassel, who said, physician failure to understand the nature of suffering can result in medical intervention that not only fails to relieve suffering, but become the source of suffering itself. Thank you very much for your listening.
Thank you, Ghazali. It's a very enlightening talk. We have some questions at the end of the session we will ask. Now it's my pleasure to introduce Dr. Jennifer Fang. She is working in our parent institute. We are now under Mayo Clinic here in Abu Dhabi, SSMC. She is the consultant division of neonatal medicine. She is the medical director of neonatology and a medical director for neonatal transport. She developed and expanding the Mayo Clinic neonatal teleneonatology program, studying the impact of neonatal telemedicine, and also using the quality improvement tools and methodologies to continuously improve the care of patients in the neonatal intensive care. She served as the medical director of the Mayo Clinical's teleneonatology program. Dr. Fang is also the vice chair of quality for the division of neonatal medicine and serves on the Children's Center Quality Executive Committee. This is my pleasure to introduce her, and she is going to talk about neonatal telemedicine, a new thing in this area for our region also. So the state-of-the-art healthcare delivery through neonatal telemedicine. Dr. Fang.
I'm Jennifer Fang, neonatologist at Mayo Clinic and medical director of our teleneonatology program. It's an honor to be a part of this year's conference. I'll be presenting on neonatal telemedicine, state-of-the-art healthcare delivery. I do have one disclosure, which is that I have licensed IP and can earn royalties from Teladoc Health, and I also own stock in the company. So I have a few learning objectives for the next 25 minutes or so. I would like to start by really discussing the system-level challenges in healthcare delivery that prompted us to develop our teleneonatology program here at Mayo Clinic. And then I'll talk about how telemedicine can be used to improve access to care and facilitate patient triage. And then lastly, I'll describe how telemedicine can improve the quality of high-risk neonatal resuscitation that occur in smaller community hospitals. So first, when we think about development of a telemedicine program, it's really important to understand the gap or the clinical need that you're trying to address with your program. And for our program, for teleneonatology, it was really rooted in the outcome disparity that we see for neonates when they're born in a hospital without an NICU. So I think as neonatal care providers, we recognize the importance of regionalization, that when at all possible, we want our high-risk pregnant women or high-risk neonates to be delivered in a hospital that's prepared to offer the level of care that they need. However, we also recognize that that is not always possible. There may be barriers to that happening, whether they're geographic, economic, or social barriers, or it just may be an unanticipated emergency. And when a baby is born in a hospital without a NICU, particularly our preterm neonates, we know that they're at higher risk for mortality as well as serious morbidity. And I included this map of the United States, which is showing distance to a neonatologist. And those darker, deeper red colors are locations where the neonatologist is in very close proximity. But the lighter and white regions are areas where a neonatologist may be quite remote. So in our country, you can see that in the center and kind of western part of our country, pregnant women or critically ill neonates could be quite a distance from a NICU. And why is this so challenging for our colleagues in smaller community hospitals? Well, in the United States, we have some hospitals that, because of their location, may deliver less than 1,000 or even less than 500 babies in a year. And hospitals are needed in these locations because they serve as a real critical access point to healthcare delivery. However, if you're a healthcare provider in these hospitals, you can imagine that the frequency with which you need to perform an advanced neonatal resuscitation is quite low. And we know that the evidence shows that if you don't use your neonatal resuscitation skills, they decline quite rapidly in a matter of 2 or 3 months. And when you survey providers in rural hospitals, what they'll tell you is that they may only ventilate a neonate 1 to 3 times a year. And we all know the importance of being able to effectively ventilate a neonate, as that's the most critical step in neonatal resuscitation. So if you don't have the opportunity to practice and perform these skills, it can be really quite challenging to both achieve and maintain proficiency as our healthcare system is currently set up. So we asked ourselves, knowing that there's this outcome disparity for neonates simply based on their birth location, is there more that we can do? Again, fundamental to optimal outcomes is regionalization of neonatal care, providers who attend resuscitations, being competent in the knowledge, the skills, the behaviors that are needed for successful neonatal resuscitation. Many hospital teams are including, potentially best practices like briefing, debriefing, and simulation-based training. But again, despite this, we're still seeing the outcome disparity for our patients. So we asked, can we use telemedicine to close that gap? Can we use telemedicine to get the neonatologist who may be, many kilometers away to the bedside virtually for these patients in smaller hospitals so they can help guide that care team and provide that additional layer of expertise and experience to really optimize the resuscitation and patient outcomes? So teleneonatology is really that telemedicine network that allows neonatologists to establish a real-time audio-video telemedicine connection so they can be at the bedside of critically ill neonates when needed. And we established our teleneonatology program at Mayo Clinic over 8 years ago. And so far, we've performed over 600 consultations. So Mayo Clinic, the main campus is located in Rochester, Minnesota. And at Mayo Clinic Hospital, we have 2 NICUs. So one is a 34-bed level 4 regional NICU, and we also have a 24-bed level 3 NICU. And it's the 9 neonatologists that staff our NICUs that also provide our telemedicine consults. Now, Rochester, Minnesota is quite a small community, and we only have about 2,500 babies delivered in our hospital each year. But you can see many of our admissions, over half of our admissions, are actually from babies born in other hospitals in our region. So again, it made this idea of using telemedicine very relevant to our practice. Our program in total supports 19 community hospitals. You can see a majority of these, 17 of the hospitals, are part of what's called the Mayo Clinic Health System, which is a network of community hospitals that spans a 2-state region. We also support 2 hospitals that are not a part of Mayo Clinic. And so if you pull all of those hospitals together, we're available to consult on about 7,000 deliveries each year. Now, when we're providing our telemedicine consults, we're generally working in partnership with the pediatrician or the family physician that's at the bedside, as well as other care team members, whether it's nurse, respiratory therapist, or other allied health staff. So what type of care are we providing via telemedicine? So if you look at these indications, obviously they're very familiar and similar to the type of care we're providing in our own NICU. We do a lot of consultation for respiratory distress, whether it's transient tachypnea of the newborn, meconium aspiration, pneumothorax. We also do many consults for prematurity, as well as review physical exam findings, and assist with advanced resuscitations or if a baby comes out and has perinatal depression. So before I move on to really looking at the value telemedicine can provide, I thought it would be helpful to share with you a video of a simulated consultation so you can really get a good idea of the level of collaboration we can achieve through telemedicine.
Mayo Clinic Admission and Transfer Center, this is Chad RN. How can I help you?
Hi, Chad. This is Julie. I need an emergency telemedicine consult for a preterm infant going to be born in Austin.
Okay. I just sent the page to our neonatologist, and I need to confirm you're calling from MCHS Austin, right?
Yes.
And briefly, what's happening with the baby?
We have a 28-week infant that will be born soon.
Okay. So, and that's our physician calling here. Let me put you on hold, and I'm going to get us connected, okay?
Okay.
ATC, this is Chad.
Hey, Chad, this is Bill Carey from Neonatology.
Say, I have Austin on the line. They have a 28-weeker that's not been born yet, and they want a teleneo conference. Can I connect you?
Yes, please. Thank you.
Okay. Go ahead, Dr. Carey on the line.
Hey, this is Bill Carey. I'm a neonatologist in Rochester. I understand you have a telemedicine consult for a 28-weeker.
Yes.
Okay, great. Hey, Chad, can you do me a favor and dispatch the neonate team down to Austin, and I'll connect via telemedicine right now.
Okay. Okay.
Thank you. I'm going to stay on the line here until I'm connected, and I'm live on video.
Yes, we have you on video.
Okay, thank you.
Thank you.
Hi, I'm Bill Carey. I'm one of the neonatologists at Mayo Clinic Rochester. Can you introduce yourself so I can understand who's on the team today?
Sure, I'm Dr. Fang, the pediatrician, and I have 2 nurses on my team today.
I'm Julie. I'm Lindsay.
Great. Good to meet you. I understand you have a 28-week baby on the way.
Yeah, that's right, and we're just getting everything ready. We have our chemical mattress and plastic wrap. We have our Neo wrap set and ready to go, and I have intubation supply should I need it.
That's perfect.
Okay, great. Anything else? Because I think baby's about to deliver.
No, I'm going to attend the baby.
Okay, all right. Okay, baby's out. Okay, we'll lift baby. Okay, we'll get monitors on. Baby's looking pretty apneic. Put that monitor on here. We're just stimulating.
Looks like you're doing a good job of that. Still apneic.
Yep, still apneic.
Julie, can you check the baby's heart rate for me quickly?
Sure.
And
rate 70.
Okay, it seems like the baby is apneic, so Dr. Fang, if you could please provide some positive pressure ventilation, that would be great.
It looks like, if you could please, tilt the chin back a little bit. Tilt
Okay.
the head back and lift the chin. There you go. That'll help with air entry.
Yep, our manometer is looking much better now. Thank you.
And why don't you breathe a little bit more quickly than you're doing right now? So maybe
Okay.
50 to 60 times a minute.
2, 3,
1
breathe.
minute.
2, 3, breathe. 2, 3, breathe. 2,
How's
3.
the heart rate, Julie?
Heart rate's still 70.
Hi. I'm not seeing very good chest rise right now, so Lindsay, can you
That's
increase the
true.
peak respiratory pressure up to 25 for me? How does
Okay,
that feel, Dr. Fang?
we're up to peak of 25, and the chest rise looks much better. I don't know if you can see that.
No, I can. It looks
But
good from here. I just wanted to get your take on it.
Yep, it looks much
That's
better.
great. How's the heart rate, Julie?
Heart rate's still 70.
Hi. How are the saturations?
They're 60.
Okay. Lindsay, if you could please dial up the FiO2 to 40%, and we'll see if that helps improve the heart rate.
Okay, we're there.
Yeah, and baby looks like baby's doing some breathing on his own.
Okay.
Heart rate's greater than
Saturations now,
100.
Lindsay?
They're at 72.
Okay, so coming up.
Yep,
And spontaneous breathing
it's
looks like it's starting to happen. Kind of intermittent.
it is. It is. Yep, and Julie said our heart rate was greater than 100, so I think baby seems to be responding.
Excellent. Yeah, do you want to try some CPAP alone for right now?
I think
Keep
so.
our eyes to where it is? Okay,
Yeah,
great.
let's try that.
Thanks for getting the temperature, Julie.
Oh, you're welcome. It's 37.2.
Perfect.
And
So it
baby's
looks like the
breathing.
baby's breathing pretty well.
Yeah. Yep.
Excellent. Saturations, Lindsay?
80.
That's great. They're moving in the right direction. Heart rate?
Heart rate's still greater than 100.
That's excellent.
And we're almost 3 minutes old, Dr. Carey.
Okay, perfect. So, look, I just got a page from our transport team. They're about 20 minutes out. Maybe one thing to do at this point would be to check a blood sugar, and if you can, place an IV to start some dextrose fluids. Does that seem like a good idea?
Yeah, I think we can do that. Thank you. Baby's still breathing well.
Perfect.
Great.
So I hope the video of a simulated consult really helped to demonstrate the type of partnership we can achieve and how closely we can work with other hospitals via telemedicine. So I want to go ahead and move on to describe how we measure the value that we're providing to our patients via telemedicine. So first and foremost, our program was about achieving more equitable access to care. So this is a map of that Midwest region, and the red numbers are the delivery volumes of some of our community hospitals. And when we think about access to a neonatologist, before we had our telemedicine program in place, less than half of the neonates born in our Mayo Clinic Midwest region had access to a neonatologist. It was only those babies who were born at the Mayo Clinic Hospital in Rochester, Minnesota, where we have our NICU. However, since fully implementing our program now about 5 years ago, we can say that 100% of neonates born in our Mayo Clinic Midwest region have immediate access to an expert in neonatal resuscitation and critical care if needed. So it really helps us achieve delivery of the right level of care to the patient where they're located and when they need it. In addition, as you might imagine, the ability to visualize the baby via telemedicine is also very helpful when you're making decisions about whether or not that patient needs to be transferred to a higher level of care. So it really facilitates very effective patient triage. So what we found with our program is that when we look at all the neonates who receive a teleneonatology consult, about 1 in 3 is able to remain at that birth hospital after the consultation. And if we look at reports from other neonatal telemedicine programs in other organizations in the US, they have similarly found that telemedicine reduces the odds of transport by about 30 to 50%. So I think this is a really important aspect of the program, that through telemedicine, you can avoid the unnecessary separation of mom and baby, that you can avoid the costs associated with unnecessary medical transport and avoid NICU hospital days. And These types of programs really help facilitate bed utilization across a region as well, making sure that when you're bringing a baby to the NICU, you're more confident that that baby does require critical care. So the last value metric that I wanted to share was that of quality. So looking at how does teleneonatology impact the quality of resuscitation. And this was a retrospective cohort study we published a few years back now, where we looked at outborn neonates who were admitted to our NICU. And we compared neonates who received a telemedicine consult to matched controls who did not. So controls that were matched on gestational age, birth weight, admission diagnosis. And then we looked at the overall quality of the resuscitation. So we identified the patients who met criteria for the study, and then we, using data abstracted from the EMR, our electronic health record, we had 2 neonatologists that were blinded to the intervention review the patient characteristics and resuscitation metrics for each study participant. And then in reviewing that data, they then assigned a resuscitation quality rating on the scale of 1 to 10. Where 1 was a very poor quality resuscitation and 10 was an excellent resuscitation. So if we look at the 92 neonates who were included in this cohort study, the average gestational age was about 35 weeks. You can see 15 to 20% of neonates were less than 29 weeks gestation. On average, they weighed 2,500 grams, though you can see we had some extremely low birth weight infants as well. Not surprisingly, the most common admission diagnosis was prematurity or respiratory distress syndrome, followed by encephalopathy. Now, in this outborn cohort, you can see the rates of antenatal steroid administration were quite low. And I think this just reflects the emergency nature of the delivery, that when these babies are delivering in a smaller community hospital, it's happening quite quickly, which you can see reflected in the high rate of emergency C-sections. So what about the primary study outcome? Well, what we found was that telemedicine did significantly improve the quality of resuscitation for these neonates. When we look at the median quality rating in the telemedicine group, it's 7 compared to 4 in the control group. And the graph on the right is looking at the percent of neonates who had a high quality rating of 5 or greater. And you can see that a significantly higher proportion of neonates had that high quality rating in the telemedicine group when compared to the control group. Now, what was it about neonates in the telemedicine group that may have earned them that higher quality rating? Well, when we looked at all of the discrete data, what we found was that neonates in the telemedicine group were significantly more likely to have many process measures completed. So here you can see that neonates in the telemedicine group were significantly more likely to have their temperature, blood glucose, and blood gas measured. And I think we all recognize the importance of performing these steps, that we know that if a neonate is hypothermic in the delivery room, that's associated with a higher rate of mortality. We need to ensure that our neonates are euglycemic and that we are appropriately ventilating them. So as we think about the value that telemedicine can bring to our patients, I thought it might also be helpful to share with you another short video that's really shares a patient story and provides the perspective from the provider, from the parents, and from the neonatologist.
On June 30th, 2019, Lizzie Stoltz called her husband Sean to tell him she had just gone into labor, 30 weeks into her second pregnancy.
He said right away, "You're kidding." And I said, no, I'm positive my water just broke.
The couple lives in the small northern Wisconsin town of Bloomer, population roughly 3,500. Lizzie had planned to deliver her second child at the Mayo Clinic Health System Hospital in Eau Claire, about 30 minutes away. However, it soon became clear that wouldn't happen. Her contractions were coming on too strong. So she went to the closest hospital 3 minutes away, Mayo Clinic Health System in Bloomer. The hospital is staffed 24/7, but there's no labor and delivery service or a neonatal intensive care unit. Physician assistant John Farm was working the emergency room and had 5 minutes to prep for Lizzie's arrival.
That's the first thing that crosses my mind, is to assemble the appropriate resources and team to be able to take care of the patients that are coming in. So that's what I did. Called Dr. Score, and then I called the transfer line in Rochester and told them that I'm going to need some telemedicine help as well.
Telemedicine allows medical providers to communicate and see patients from an off-site location through a machine just like this. Dr. Christopher Kalura, a Mayo Clinic neonatologist in Rochester, Minnesota, quickly appeared on the telemedicine machine in Bloomer, ready to assist John.
We have controls in order to zoom in on different areas of the room and improve our audio, talk to providers with a handset if needed. Short of us standing right there with the team, it's the next best thing.
By the time Lizzie arrived at the Bloomer emergency room, she was ready to push. By now, on-call family medicine physician Phil Score had arrived at the hospital. Together, he and Dr. Kalura, over 100 miles away, worked to deliver the baby.
It was literally like having a specialist looking over your shoulder. And there was times where he would pan the camera and have a conversation like, hey, what's your name? Okay, we're going to do this is what I want you to do. And yeah, it was remarkable.
The baby was finally delivered, but she was bruised and not crying.
She was very limp and blue and not breathing.
John intubated the 3-pound baby named Madeline Grace. Through it all, Dr. Kalura remained by his side on the telemedicine screen, taking the guesswork out of caring for such a premature newborn. A Mayo Clinic neonatal flight crew then took baby Madeline to Mayo Clinic in Rochester, where she would receive care for the next 44 days. Madeline had become the first baby born at the Bloomer Hospital in years, and the first with the support of tele-neonatology.
It's the patient, the right care at the right place at the right time. That's what telemedicine does.
Madeline is now thriving and getting used to life at her real home.
It's broken sleep with a lot of smiles.
Yeah.
That's what it is. She's going to be demanding. She'll be a fighter, that's for sure.
For the Mayo Clinic News Network, I'm Kristen Everett.
So the last thing that I wanted to share with all of you was the results of a study actually we just published that was looking at the perceptions of teleneonatology across 5 NICUs and 27 community hospitals in the United States and Canada. And this was a survey that we sent out to providers at these sites, and we used a validated implementation science measures that really looked at evaluating provider perceptions of the acceptability, appropriateness, and feasibility of teleneonatology. And these 3 measures included a total of 12 statements, and then the respondent rated their level of agreement with each statement on a 1 to 5 scale, where 1 was strongly disagree and 5 was strongly agree. So we sent this out to 365 providers and had a response rate of 56%. So when we look at the results of this study, this was the measure of acceptability. And you can see that this included 4 statements asking if teleneonatology meets their approval, is appealing, and if they like and welcome teleneonatology. And what we found was that the percent agreement with these statements was very high, anywhere from 88 to 98%. And you can see the mean score also very high, 4.5 to 4.7 on that 1 to 5 scale. Now, what about the measure of appropriateness? So these 4 statements were asking providers' perceptions on whether teleneonatology seemed fitting for their practice, if it was suitable, acceptable, or seemed like a good match. And what we found was that appropriateness was again rated very high, that the percent agreement was anywhere from 93 to 97%, with mean scores 4.6 to 4.7. Now, the last measure was one of feasibility, where providers responded to statements asking about implementation, if teleneonatology seemed possible, doable, and easy to use. And again, we found the percent of agreement was very high, anywhere from 88 to 99% of providers agreed with these statements, with mean scores of 4.4 to 4.6. So I think what this study shows is really a broad receptiveness to teleneonatology for both providers in NICUs that would provide the teleneonatology consultation, as well as providers in smaller community hospitals where they would receive the teleneonatology consultation. Now, when we looked at these ratings across different provider roles, years of experience in neonatal care, or previous telemedicine experience, there was no significant difference between those groups. And there was no difference between NICU providers and community hospital providers. What we did find was a small but significant difference between providers and community hospitals with a level 1 well newborn nursery versus a level 2 special care nursery, where providers in that level 1 nursery rated teleneonatology significantly higher across these 12 measures. So in conclusion, I hope I was able to share how there were system-level challenges to healthcare delivery for neonates requiring resuscitation or critical care that really drove us to develop our teleneonatology program. That telemedicine can be used to improve access to resuscitation expertise, facilitate patient triage, and really improve the quality of these resuscitations. And now what we're learning is that newborn providers in both NICUs and community hospitals perceive teleneonatology to be acceptable, appropriate, and feasible for their practice. So I would just like to close acknowledging my amazing neonatology colleagues that provide these consultations, my friends and colleagues in Mayo Clinic Center for Digital Health, and my fantastic operations manager, Beth Kriofsky. And with that, I look forward to answering any of your questions. Thank you.
Okay, thank you very much, Dr. Fang. We will be having you in a panel discussion. We have definitely a few questions, and we try to establish the teleneonatology here in UAE with your help. Our next speaker, there are two speakers actually. First is Dr. Akuma. He's acting chair neonatology and consultant neonatologist at Connie Hospital, Abu Dhabi. He's graduated from the UK, and he was consultant position at the Leicester Royal Infirmary in 2009. He has extensive clinical experience and had several leadership positions. He has several published papers and received of UK Consultant Clinical Excellence Award. His area of interest is antenatal counseling, echocardiography, neonatal nutrition, risk management, and mortality review. With him, his presentation is sharing by Dr. Ahmed Muharram. He is a pediatrics and neonatology registrar at Royal Aberdeen Children's Hospital, NHS Scotland. He was granted the Arab Board after completing the neonatal fellowship training program at Cornish Hospital. So they are going to share with us the evaluation of the accuracy of oscillometric blood pressure measurement in comparison to invasive arterial blood pressure readings among preterm infants born less than 29 weeks of gestation. So over to you, Zandy.
Good evening. On behalf of my co-presenter, Dr. Ahmed Muharram, I want to extend our thanks to the organizers of this conference for extending invitation to us to present our work in this prestigious gathering. We are very grateful. We'll be presenting the study we did evaluating the accuracy of oscillometric blood pressure measurements in comparison to invasive arterial blood pressure readings among preterm infants born at less than 29 weeks gestation. There is no conflict of interest to declare, and this study received no external funding. As an introduction, we all know that oscillometric blood pressure measurement is a common point of care assessment that is done regularly in all NIC units worldwide. However, its reliability in comparison with invasive arterial readings, which is the gold standard, has been questioned. And because of this, we aimed to compare BP readings in preterm neonates born less than 29 weeks, obtained by oscillometric methods which simultaneously measured invasive arterial blood pressure. We had this research question in mind. Can we reliably use oscillometric blood pressure measurement to measure blood pressure and monitor blood pressure in preterm infants? And in trying to answer that, we're also interested in looking at the demographics of such preterm infants and their clinical status and variable during the times we took those recordings. We also wanted to know how and to what extent do oscillometric readings differ from invasive ones. And finally, we also wanted to look at how the different clinical variables that are obtainable in these children and babies, how it influences any difference, if any, that we might find between using oscillometric and invasive methods to monitor their blood pressure. This was a prospective observational study. It was done in our center, the Corniche Hospital here in Abu Dhabi. And we did the study in the year 2019, beginning from 1st January of that year to the end, the 31st of December 2019. All neonates admitted to the NICU born at gestational age of less than 29 weeks were eligible to be enrolled. Such babies should be aged between 0 to 60 days and also have a functioning arterial access prior to their enrollment. Those who had complex congenital heart diseases, limb abnormalities, lethal congenital conditions, or felt to be in a moribund state were ineligible and excluded. Our study obtained ethics approval. And in order to be approved, there were things we did at the beginning. We produced a study information leaflet in English, but then translated to Arabic. We also prepared a study consent form, which was also done in English and translated also into Arabic. Before starting, we created awareness of our study within our department. We gave lectures, we gave seminars to create awareness among the staff so that the study could be supported. The nurses were crucial to this study. Yes, they record blood pressure routinely, but because of the study we're going to do and to be stringent in it, we trained our nursing staff, making them to become conversant about our study protocols and the data collection methods. And only those who underwent that rigorous training took data for our study. We prepared a data collection pro forma, and there was a study box for our study, which contained all these documents that were relevant to the study. To analyze our data, we used the SPSS version 25 for doing the analysis. This is what our data collection pro forma looked like. As you can see, we made provisions to collect the relevant demographics that we're interested in. We also made provision for places to collect the relevant variables that we're interested in. We also gave space for the nurses to record the readings measured using invasive method and the oscillometric method. And these were the things that we collected. Regarding demographic information, we collected information regarding gender, gestational age, birth weight, whether the baby was appropriately grown or small for gestational age, their postnatal age at the time of enrollment, and the most recent walking weight. The clinical information that were of interest to us included whether they were receiving inotropic support during the time of the study, whether they were ventilated and what mode of ventilation support they were on, were they sedated, were they receiving muscle relaxants, were they clinically edematous, what is the site of the intra-arterial access. For those who had umbilical arterial catheters in place, we wanted to know the size of the catheter used and the place of the tip of the catheter. Is it high placed or is it low placed? The size of the peripheral arterial cannula used for those who had peripheral arterial access was also collected, and the limb that was used for the oscillometric measurements. For the invasive blood pressure readings, the nurses did them twice every day, so once per 12-hour shift, and they collected systolic, diastolic, and mean blood pressures readings via the invasive arterial route, and they did that every minute for 3 minutes. And like I said, this was done as long as the baby had a functional intra-arterial line. The non-invasive readings were also collected twice every day, once every 12-hour shift, and the nurses measured this immediately after they collected the invasive BP readings. They read the non-invasive readings every 2 minutes, just to give the limb a time to recover. And they also collected 3 readings. Of all these 3 reasons that are documented, when we came to the analysis, we took the averages. So in essence, this is a summary of what we aimed to do. All the readings were done and taken when the baby was either supine or prone. The baby was either asleep or in quiet awake state when the recordings were done. It is also done 30 minutes after their last feed or after the last medical intervention. Those were the conditions for the nurse to take the readings. For the invasive arterial blood pressure, when they are initially sighted, they are usually zeroed and calibrated at the level of the right atrium. And once every of the 12-hour shift, another calibration is done. At the time of collecting the recordings, the nurse must check that the position of the line is still satisfactory, that is at the level of the right atrium. If it is not, then a recalibration needs to be done. Likewise, the arterial waveform on display on the monitor ought to be normal. If it is not, a recalibration is needed. And during such recalibration, there is a check made to ascertain that the line doesn't have any air bubbles which need to be let out before they can collect the invasive BP readings. For the non-invasive measurement, we used a disposable BP cuff. Once a baby is enrolled to the study, the nurse will measure their mid-arm and mid-calf circumference. And with that measurement, they selected an appropriately sized cuff. The cuff should be the one that gives us a width to limb circumference ratio of 0.37 to 0.47. That was the manufacturer's recommendation. And when they are taking the reading, they will select a most suitable limb that has the best ease of access. And the readings are also taken at the level of the right atrium with the cuff marking matching the arterial location. And if all the limbs were free to be used, we preferred to record using the right arm. I want to talk a little bit about these two statistics because our findings will be displayed in a greater extent using some of these statistics. Statistics is not one of my strong points, and it's always usually good to refresh yourself even if you have a mastery in the subject. We used Bland-Altman statistics and plots a lot, which is a statistical method that you use when you want to compare the measurement of an indices using two techniques. You want to assess their degree of agreement. What you do is that you plot the differences between the measurements using these two techniques on the y-axis and the averages of both measurements on the x-axis. When you have done that, you have a line in the middle of the plot, which is like the zero line. And also, you also have an upper line and a lower line, which are like the 95 confidence intervals, where all these differences in your measurements will stay. And just around the zero line, you have what we call the average bias. And the extent of the bias is a measure of the degree of agreement between the two techniques that you're using to measure that variable of interest. The limit of agreement, as I've said, is obtained statistically. The interval between the upper and lower limit of agreement represents the interval where 95% of the differences between both techniques will lie. However, whether this agreement is sufficient for one technique to reliably replace the other depends on clinical judgment and comparison against other research evidence that applies to your indices of interest. The other statistics that we used is the Pearson correlation coefficient, which is represented with an R. And we utilize this type of statistics to find out whether there is a linear relationship between two variables. So in our display of results, you will see that we used it to explore whether the differences we found between the oscillometric values and the invasive arterial readings, whether they had a linear relationship with the clinical variables of interest that we looked at during our study. So I just put it there as an explanation to help us follow the study results as my co-presenter, Dr. Ahmed Moharam, will be presenting subsequently. Over to you, Dr. Moharam.
Thank you, Dr. Akuma, for starting the presentation, and many thanks for your support during running this research. So we will move now to the results and some statistics. So as we can see, a total of 98 babies born less than 29 weeks were admitted to formation neonatal intensive care unit during the study period. 25 of the parents were approached for the recruitment. 6 parents refused to consent, resulting in a total of 19 subjects enrolled in our study. A total of 111 paired invasive blood pressure and non-invasive blood pressure sets of average readings for systolic, diastolic, and mean were obtained for the study cohort. Looking to our demographics, the mean age of recruitment was 2.2 days with a minimum of 1 day and maximum of 20 days age. And there was a 4 readings median for the number of readings per recruit. And regarding demographics, there was a vast majority of our study population were male population, and most of our study population were appropriate for gestational age, and most of the age group ranged between 27 to 29 weeks gestation. Looking to the variables that we have collected and included in our pro forma, it's worth mentioning that regarding window ventilation, 61% of our population were on non-invasive ventilation during the study, and 37% were on conventional ventilation. And regarding the arterial line, 94% were using a central umbilical catheter, while 6% used peripheral arterial catheter. And regarding the size of the catheter, the vast majority, which was 84%, we used 3.5 millimeter, while 7% only 2.5 millimeters, and 9% 5 millimeter catheter. And then when we compare the average measurement obtained by the non-invasive method to the invasive method, it's obvious in this graph that there is a consistent higher numbers when we use the average non-invasive compared to invasive in all systolic, diastolic, and mean blood pressures. Yeah, but when we look to the correlation between both methods, actually it's a given fact that there will be a correlation in weight, but we use the Pearson correlation to look to the strength of the significance of correlation between both methods. Looking to the systolic blood pressure, the R value was below 0.4, which shows that there is a weak correlation between systolic blood pressure taken by non-invasive compared to invasive, while in diastolic and mean, the R value was more than 0.4, denoting that there is a moderate association between both methods with regard to diastolic and mean blood pressure measurements. Now we will have a look on the Lund-Altman plots. As Fatuma mentioned earlier, it compares that it plots the difference between the invasive and non-invasive measurements on the y-axis to the average blood pressure measurement on the x-axis. And this illustration is used to illustrate the systolic blood pressure. There are 3 lines. The upper line is the upper limit of agreement, and the lower line is the lower limit of agreement, and the middle line is the line which shows the average bias. So as this graph presents the systolic blood pressure measurement, the average bias, as we can see, is minus 6.6. When we move to the diastolic, we can see on this graph that the average bias is minus 1.1. And when we move to the mean blood pressure, the average bias is minus 1.4. From the 3 Lund-Altman plots, it's clearly shown that oscillometric measurements tends to systemically overestimate the blood pressure taken by the invasive method. Looking to the systolic measurement, there is a higher variance with a bias of minus 6.6 on average, while in mean and diastolic, the bias is smaller. It is minus 1.4 for the mean blood pressure and minus 1.1 for diastolic blood pressure. We look to other studies. So, for example, this study was done in Vienna in 2018, 1 year before our study, and we looked to their results, which showed that also regarding to mean blood pressure, the bias is small. Here it was minus 1.4, which is almost similar to the number that we got from our study. And also, their study shows that there is a considerable bias when it comes to the systolic blood pressure. In their study, the average bias is 6.1. So we should be, they recommended that we should be cautious when we use the non-invasive blood pressure technique to measure the systolic blood pressure. And then we looked into the variables that we included in our study to see if this is affecting the numbers. So in this table, we can see a comparison between the mean difference between invasive and non-invasive compared by the different clinical and demographic variables. Looking to the column on the right side, the mean blood pressure, we couldn't highlight any of the variables that can affect the numbers at all. But in the middle, in the diastolic blood pressure, we highlighted gestational age as a variable that could affect the reading. And on the systolic blood pressure, we have three variables that could affect the reading. First, weight, gender, and size of the catheter. So, firstly, when it comes to mean blood pressure, the difference between the invasive and non-invasive was not affected at all by any of the variables. When it comes to the diastolic blood pressure readings, gestational age was one variable that could affect the readings. So we looked further into that. And the systolic, the gender and birth weight and size of catheter could affect the readings. So we have done another interesting correlation to look to the further to these variables and its effect on the our readings. And we have seen that in systolic blood pressure, the weight associated with positive significant correlation with the difference in the readings. However, in diastolic, the gestational age showed no significant association with diastolic. So for diastolic now we are fine because recent correlation showed that there is no significant association with gestational age. And when we have done the linear regression, just to answer the question, is this association has a direct effect on the reading? So the linear regression showed that there is no direct effect of these variables on the reading despite of the association. So to sum up and conclude, so the difference between invasive measurement and non-invasive measurement for the mean and diastolic blood pressure was not significantly associated with any of the variables. However, the difference between invasive and non-invasive systolic blood pressure was affected by the birth weight and size of the catheter. And to answer the question of our study and to come to the conclusion, can oscillometric blood pressure measurement be used reliably to monitor blood pressure in preterm infants? The answer is, according to our result, oscillometric blood pressure measurement can be used reliably to monitor mean arterial blood pressure in preterm infants, especially when the range is between 25 to 50 millimeter mercury range, and the different demographic and clinical characteristics do not impede such reliability. However, there is a possible bias of overestimation of systolic blood pressure by non-invasive techniques, which demands clinical attention by the care provider. Thank you. Here we come to the end of the presentation. Thank you so much.
Okay, thank you very much. Very nice, thought-provoking talks. So I will start with Dr. Babar Shimit. Very simple question, Dr. Babar. What do you suggest to the young and enthusiastic investigator how they should start?
A very important question. I think almost invariably I will say start small, and learn. Don't try to do a big multi-center trial as your first research project. That would be so. You have to take small steps before you can take big ones. And I think the second piece of advice would be, you wouldn't dream of going into a lab and just start mixing some reagents. You would, get a solid education in how to do proper lab research in whatever methods you will pursue. And it's actually no different in clinical research. You need to understand the methodology, and you need to at least understand statistics to the point that you can have an educated conversation with your statisticians. So basically, you know, I've recommended to every single one of my trainees in the past, mostly neonatal fellows who expressed an interest in this line of research, to do a master's in clinical research methodology and biostatistics. And the difference really shows, and many have done that. And there are some people who are doing extremely well now in mid-career.
Yeah. The other question for you, Dr. Barber, that the studies, there are well published or well-read studies like CAP trial, and people implement it. But there are many studies who have very good results, but the people are very afraid to implement that or to think about it twice. And then on top of that, there's a written that, the further study is needed. How you take this question when many of the studies said further studies needed?
Do you want to give me an example of a well-done study that people don't, you know, of a treatment that people don't implement? What were you thinking of?
For example, we are just in the morning talking about the surfactant administration.
Sorry, the what?
The surfactant administration without the intubation. In the morning, Dr. Peter Davis discussed about that. And in the Europe, they are almost like everybody is doing, especially in the Germany and the UK. But in the USA, there are very few, or the Canada, very few centers are doing this. And Peter Davis is also enthusiastic to continue that technique. But still, they are saying that there are a lot of further studies needed. So,
right. Yeah, I'm glad you picked this example, because I think it points out to the extra steps that need to be in place before you can translate the results of a trial into practice. And your example is perfect. And I'm actually German, so I have a little bit of a closer understanding of what went on in Germany and in Cologne especially. So, so a drug trial is easy to translate, like the CAP trial, right? I mean, you have a fixed drug, you have a fixed dose, you have a schedule of how you give it and the route of administration. It's easy for everyone to safely copy. This is definitely not the case with the LISA surfactant administration. And you cannot imagine the control there is in some of these centers that have pioneered it. They won't even let every nurse come close to an extremely preterm baby. They are highly selected. There's one super trained physician and one exceptional nurse allowed to even touch these babies and come to the delivery room. And now translate that into a US context where people are learning on these babies. Residents, fellows, all sorts of people, RTs. You cannot compare it, and a lot more has to be in place for the translation of that type of research. And it's not just more trials need to be done by super experienced people, but in the real world, it has to be shown to do more good than harm.
The other question for you, which is if you take a look at the NRP new guidelines and the NRP new edition we just published, if you go into the detail, most of the recommendations either they are the weak or not very strong recommendation. So how this is, and then anybody else can say that, okay, my experience is better than this recommendation. It is very weak evidence and weak recommendation. So how you that sort of scenario?
Well, the delivery room NRP, of course, refers to delivery room research, and that is a very recent advent in neonatal research, right? We just need to do something. And, I saw Dr. Saubstadt in the speaker's room. I think he's credited for almost single-handedly having put on the map that it is wrong to start resuscitation in every newborn baby with 100% oxygen. We just did it because nobody had studied it properly, and it is his credit, really. to have changed that practice for the better. But the problem with the delivery room research is that it's still pretty sketchy. It's very hard to do, which is probably why there haven't been enough studies. And here again, we have a perfect example how a new method crept in. And again, Europe seems to be always in the forefront, and that is sustained inflation. And so, it was basically already routine in some European centers. And when it was studied in a large international trial, it was stopped early by the Data Safety Committee for seemingly, and I think realistically, causing more harm than good in these, certainly not any good, and possibly some harm in these very fragile and tiny babies. So I think being guarded and careful and not jumping on the bandwagon is the right thing in many situations.
Thank you, Dr. Barber. For Dr. Kolas, I will catch him tomorrow. He is giving these 2 talks. Hassan, come to the ethics. Dr. Barber should talk about the ethics. You know, where we are working, the ethical principles can be changed. But you didn't comment about that if the parents said that, no, I don't want this baby, and you have to remove the tube or you have to do what you will do in this situation, not the other way around, that the parents want to do everything. This is the different story. But we face this problem also, that the parents know the baby, parents know other thing, they are very educated parents, and they say we don't want you to do any intervention.
I think that's why this is a gray zone for everybody now. If you are practicing in a place where the American Academy of Pediatrics or Sweden Neonatal Society are declaring the space that you can work with as a physician and give you that opportunities to work with parents, then and the local law. This is why in NRP they said you should respect the local law, because in certain countries you are not allowed to follow what the parent wants in terms of withholding support or withdrawal support, and you could be in trouble as a physician. But once you have that freedom, then we have 2 things to consider. Number one, also the autonomy of the physician. When they feel that I cannot practice in the way the parent dedicate, some care that might be withholding a human being the right to live. So in this setting, I think more than one person should be involved: the obstetrician, the neonatology, sometimes the ethics committee. Some policy and guideline from every hospital should start to be formulated regarding this. For example, in UAE, I think we follow. I know many places are not following exactly the law, but the law is to probably go with resuscitation if the parent requested, once you are above 22 weeks. Now, withhold of support or requesting not to give support, we're not facing it. Like, for example, in 5-6 years in UAE, I never had a parent requesting the opposite. So we haven't been actually into that, but I'm willing to hear if anybody has a comment regarding this.
The other thing is you said about the more towards to give the right scenario, so 22 weekers to 23 weekers. So what do you think? We have to talk to the parents and then give the support, or we automatically start giving support? Resuscitate these 22 plus weekers.
I said that local data and local experience and ability to save life decide the number. If you don't have any survival after many trials of 22 weeks, and you're seeing that you are exposing these babies to pain and suffering, prolonged dying, then there is no point. They become futile medicine, and it shouldn't be offered. But if there is a chance, 1 in person, 2 in person, I mean, it's a number. Then futility definition will not apply, and then we we start to be challenged with, the dilemma of ethics and comfort. And here also some religious, guilt and feeling that you are not offering the right thing to certain and injustice to this population.
Come to Jennifer. Jennifer, I will email to you because we are now in the same institute and we really want to, because we are under Mayo now. So we really want to develop this program here. So my first question is regarding the ethics. So what are the ethical responsibility of a person who is sitting far and watching everything as you showed in your video? How it is legally tackled?
Yeah, thanks for that question. So the way we work it here is that, we provide this service under either a service level agreement or a contract. And we always require that there is a physician present at the baby's bedside in person. We're not there to replace the pediatrician or family physician. So our obligations are to provide the consultation and the guidance, as you saw us do in the simulation. So we're there to assist the team, as they're working through their assessment, planning their next steps for interventions during the resuscitation, interpreting chest x-rays, blood gases, all of those things as we move through the resuscitation and stabilization of the infant. So, but it is under a service, offered under a service level agreement if it's an internal site to Mayo Enterprise, or a contract if it's through with an external site.
Okay. The other thing is that what about the training of NRP or resuscitation? You can offer that?
That's also a great question. So all of the providers, and the birth hospitals need to be trained in NRP. What we offer via telemedicine is when these hospitals are doing their NRP training courses, we will connect via telemedicine when they're doing their mock codes, their simulation and debriefing sessions. When they're doing one of their larger, more in-depth codes, they'll actually activate the service, and then a neonatologist will connect and we'll work with them through the simulation. So we found that to be very helpful, I think, for across multiple fronts. One, it helps, disseminate knowledge. For example, the 8th edition of NRP, relatively minor changes with that, we can help make sure those are clear to the community hospital teams. They gain experience with interacting with us via telemedicine, making them more comfortable to activate the service clinically. And it's also nice for us because it really does help us, build and establish the relationships with these teams, as they have new physicians come on board or new nurses. It's a really nice way to interact with them and establish that kind of trustful relationship.
So I know that you are working a lot on this telemedicine and teleneonatology, and your this data is impressive. That in 2016 only 43% or 49%, and now is almost 100% getting the desired of the appropriate care. What about the other thing, other field other than neonatology? You are working on that also in the field of in the specialty of pediatrics.
Yes, outside of neonatology, we have our perinatologists, so our MFM physicians. They will do kind of the video visits to our community hospital sites to do that prenatal counseling, to provide that access again to the maternal fetal medicine expertise. So, and then if we move as babies then get older, we also have, for example, pediatric cardiology, who will do, and this is, I think, pretty common now, remote echocardiogram reads, and they also do a lot of outpatient video visits. So we're seeing a lot more digital health within, the full spectrum of care in pediatrics, whether it's, inpatient, outpatient, or, video visits to home. So I think it's pretty exciting time to see how we can extend the reach and deliver care to our patients.
So definitely I will be in touch with you. Dr. Akuma and Dr. Ahmed, very nice project. I have one or two questions regarding the size of or the proper size of the cuff you use. Did you take this into consideration? Can you unmute yourself, Akuma, or Ahmed?
Okay.
Yeah.
Thank you, Junaid. If you remember when I was talking about the methodology, we went in depth as to how we chose the curves. They were measured before you even start, and there was a ratio that was desirable based on the manufacturer's recommendation. A circumference width ratio that was between 0.37 to 0.47, and that was what we utilized.
Ahmed, in your conclusion and in your results, you didn't find any difference. So what is your preference now? Because the small babies, we automatically put the USE. So you still prefer the peripheral method or non-invasive method as compared to this?
Well,
okay,
Muharram, you can talk. Go ahead.
Thank you, Abu. So looking to the evidence, the gold standard is the invasive blood pressure measurement.
That's what I asked, yeah.
Yeah, so this is the gold standard and this is evidence-based. What we wanted to look at is how accurate is the oscillometric blood pressure reading, especially in extreme preterm babies. And we, according to the conclusion that we came up to, is that when it comes to mean arterial blood pressure reading, the bias is small, so we can use the oscillometric reading to measure mean blood pressure. But we should be cautious when we interpret the systolic blood pressure because there is a tendency to overestimate the number, and also the average price was higher. So it is a reliable, but the gold standard will remain the invasive blood pressure.
Okay.
Just to add to it, the question we wanted to answer has got clinical relevance. Clinical relevance in the sense that there are so many times you have some of these small babies whom we are monitoring their blood pressure, and you lose the invasive access and you don't have them. What then do you fall back to? Everybody will go back and measure it non-invasively. So it's a question of what we are measuring and recording meticulously day and night. Does it have any reliability or not? That was the question we wanted to look at. And if you look at those three indices we measure, systolic, diastolic, and mean, the one that was least affected was the mean by all the other variables. It is a shame that our numbers were not big, although the pairs samples we measured was over 100. And we also showed a study that was published just before we started, which came to almost the same conclusions. If you read a lot of the literature, it is almost the same, that if you are going to pick any of these to rely on, then they pick the mean non-invasive if you cannot measure it invasively.
Okay, with that, thank you very much. If I have a few more questions, but because of the timing, I have to finish. I will send definitely to Dr. Jennifer and Dr. Barbara. Akuma and Kasavne is my colleague here, so it's very easy. Just give them a call and ask them. So we will do the email. And tomorrow morning we have a session, 2 talks by Professor Ola Sagastar and also another our new colleague on non-invasive ventilation. So inshallah, whoever can join tomorrow morning, not morning, it's afternoon, it's 1300 here, yours early morning. So very welcome to join. So thank you very much once again. And
Thank you.
we will see you all.
Thank you.
Thank you.
And that concludes the first day of the 11th International Neonatology Conference. I hope you were able to gain insightful ideas from our estimated speakers today. And desiring for more of this educational activity, once again, I would like to thank the organizations that supported this event: Children's National Hospital USA, Children's Hospital of Philadelphia USA, KC Pharmaceuticals, Sobi Pharma, Roche, Prolacta. Once again, this is Amira, and it was a great pleasure to be your host today. And on the behalf of MENA Conference, thank you and good night.